Okay, hi, this is Todd Haywood with the City Pulse and Kyle Kaminsky, Linda Vail, the Ingham County Health Officer, and Adenike Shoyinka, and I'm probably just mispronounced your name, and I apologize because I'm terrible with names, who is the Chief Medical Officer for Ingham County. And we're here to talk about the new COVID-19 vaccines and what plans we have or don't have and where we're at with that, because it is moving so fast. So, Linda, I'm going to start with you in terms of what are we looking at in terms of distribution? The word is that December 15th is when the vaccine is going to be hitting the street and being distributed. That's what we're reporting.
That is pretty aligned with what we're hearing. I think we're hearing that the FDA, excuse me, the FDA is going to meet, I think on December 8th, or maybe it was the 10th, right in there somewhere, to make a decision on the emergency use authorization. So that's the first thing that has to happen. The FDA actually has to give the emergency use authorization to the vaccine, and that has not happened yet. I don't think anybody's anticipating any problems with that, but it hasn't happened yet. The next thing is the once the emergency use authorization goes through, then it goes to a committee called ACIP, and Nikkei will tell you it's the immunization practices gurus of the country who basically set the guidelines then for the immunizations, ages, the dosage, all of that sort of thing. So those two things should happen fairly rapidly, is our understanding. And we too are hearing that probably around December 15th. Now, I will tell you, at one point I heard December 10th. At one point I heard December 1st. So I'm not going to promise you December 15th because I didn't promise December 1st or December 10th either, and neither one of those look like they're going to happen.
Okay. Well, didn't the CDC just approve who to apply the vaccine to first? Was that the ACIP committee that did that?
The CDC is coming up with priority groups.
Okay.
There's more to it when it comes to ACIP and some of the protocols around or guidance around immunization.
Okay. So as health officer, what are some of the barriers that you're hearing from healthcare providers as well as from the public as it relates to this vaccine?
Well, I mean, one of the barriers, flat out, is that the vaccine is not coming all at once. And so, we're going to see vaccine arrive for healthcare workers as well as long-term care residents. And then some time after that, hopefully fairly shortly, it will move on to, I believe, essential personnel. So that will include law enforcement, fire, some folks like that, probably, some other essential personnel. And then after that, it goes to a group, I think, over 65 and with underlying health conditions. And then it keeps rolling forward from there. So all of that is going to take a number of weeks. So that's one of the barriers, is that, people hear the vaccine is coming and it's not going to be available for everybody right at the very beginning. And the other thing is the, skepticism about the vaccine for a lot of different reasons. Some of that is, just due to the fact that it happened quickly, and we're not accustomed to this happening quickly. We've heard narratives about the fact that, you can't get a vaccine through this quick. That's just never going to happen. The FDA takes too long. Clinical trials take too long. And, more or less, yes, they do. I used to work for a pharmaceutical company, and I've been part of, clinical trials and FDA submission processes, and they are lengthy processes. But I think what I'm hearing from Dr. Fauci is it was not a cut corners kind of thing. What it was really an all hands on deck sort of thing. I used to actually work for Pfizer, and I'm sure that they just pulled everybody there to the extent that they could onto this project, including all of the people that interface with the FDA to move all of the paperwork along that needs to go through with, the safety and efficacy studies and the clinical trials. So that's one of the things that causes people some concern is, it came out fast. Is it going to be safe? And the rest of it is just, just the typical thing we are seeing right now with COVID, which is a very divisive opinion about what COVID is and what COVID isn't, which then plays out with a vaccine in kind of the same way. People who want to just rebuff the vaccine is probably as useless as they think COVID is non-existent, and and that is basically some messaging we're going to have to get around. I mean, all of those different things are things we're going to have to work with. You particularly have populations, young people who tend to not get flu shots because they think they're healthy and robust and young and don't, and they might not, trust this. I'm hearing that this generation is kind of not as trusting of government in general, and this is coming out from the government. And then you have people of color who have a long history, of certainly not trusting anything that comes out that seems experimental after the Tuskegee experiment, and that has laid a path of rightfully so distrust in the African American and Black community regarding lots of medicine, and particularly anything that seems experimental. This is not experimental, so we're just going to have to work with a lot of that messaging in order to get past those barriers. So those are some of the ones I can think of right off base.
Okay. Dr. Shoyinka, as an infectious disease specialist, I assume you've been following these studies pretty closely. How are you feeling about the data that, at least that we've seen publicly reported as it relates to this? Is 30, I think Pfizer did 30,000 people in theirs and Moderna did 40,000, something like that. Is that a good sizable study group to really make an efficacy and safety decision on a vaccine?
Yeah, so that's a good question. But yes, 30,000 it's a good number. It won't give us all the information that we'll need long term, but it is enough to provide the safety and efficacy numbers. And I'm sure that, a lot of those numbers, that number 30 was not just, pulled out of anywhere. They would calculate what exact number is needed to treat or to expose to the virus to determine what safety and efficacy should look like. And from what we've seen, a lot of those people, about 90% efficacy was documented of the people who developed infection within the Moderna group. Out of, say, almost 200 of them, I believe maybe 195 of the people who developed infection, only 11, I think, were of the people who did get the vaccine. Everybody else got placebo. And the people who did get infected otherwise who did have the vaccine, didn't have a severe illness as the people who did not get the vaccine. And so those are some things that we've seen early on to indicate that, it is something that will be of great benefit, and it does appear to be safe. One thing we do need to note is that when we talk about the speed at which we've developed this vaccine compared to what we've had before, there's a lot more technology that we've used now, that we're using now. Just like Linda said, all hands on deck, plus way more technology than was ever used for any other things before. So that accounts for some of the speed with which the vaccine has been developed this time. And so that should give us a little bit of more comfort in understanding why it's happening so fast and it's not necessarily being rushed, so to speak.
Now, one of the things during the early phase of the clinical trials was there was a real push to recruit people of color for the trials. Do you feel comfortable that enough people of color actually were brought in for these trials? Because we do know that sometimes there are significant differences in how people respond to vaccines based on age and race and ethnicity. I mean, there's a whole lot of variables there. Do we have enough variety or diversity in the clinical trials, do you think?
So I honestly can't tell you the exact numbers, but I will say that on the average, I think that it's safe to say that there wasn't an equal distribution of um, patients in terms of race and ethnicity, right? For one. And just like you said, there's a lot of diversity in terms of the way people react to, you know, infections or react to vaccines overall. Another thing that that wasn't really uniform, and that's kind of like the normal thing that happens when you do vaccine trials like this, is that the cohorts that are chosen are really, you know, healthy individuals at baseline. It's just like, you know, there's a selection. um, I hate to use the word bias, but that's kind of what would happen. And then subsequently, as we determine how, you know, we have a basic level of that safety and efficacy, then we broaden things and we're able to see things as we move into the next phase of those trials, where we're now in, you know, phase 4, and we can see things a little better as we distribute it in the public. So no, we probably don't have enough, and that's not unusual in these kind of trials, but it's not enough to, it's not something to say, no, it's not good enough to use in people of color or in other, you know, other people. The other group of people that we don't know anything about is children and pregnant women. And that's, they were not included in those trials at all. So when we see how things look like, then more trials for that particular cohort of people will happen. And as we distribute the vaccine this time, more studies will occur to, you know, make better determinations about, you know, race differences and age differences and, you know, immunocompromise and all those other things.
Now, also within this science, we still don't know how long any immunity, whether from having the virus or from this, lasts.
Yeah.
Are you anticipating that this is going to become an annual?
It's possible. There have been speculations that that is possible. Based on the trial information we have now, none of that is clear. That is something that only time will tell, apparently, from everything that I have read or heard. So that's yet to be seen.
Okay. Uh, Also within, so when the CDC has said, you know, these are our priority targets, and it's healthcare workers and then long-term care facility residents and workers. Do we include in that context, and Linda, I'd like you to weigh in on this as well, the folks that are doing housekeeping in the hospital, that are, you know, washing the linens and delivering the food and transporting the patients, who we don't traditionally think of when we say medical providers?
Right. So in hospitals right now, most health systems are tiering their healthcare workforce overall. And, you know, we do have what we've all seen, like the phase 1A, which is, you know, healthcare workers, which is a more broad category. But within that group, there will be people who will be in front of the line. So people who have direct patient care, ICU staff, nurses and doctors, people who work on an internal medicine floor, and of course, emergency room staff too, will be the first people, like number 1 to 100 will be those people. And then other specialties, you know, other things too, you know, including in that you have, you know, respiratory therapists. And, you know, if there is, you know, I don't know, environmental worker who works in the ICU, maybe they would also be, you know, along those lines. But based on my understanding from the health systems and who I've spoken to, that's the way it'll start. And then the rest of the healthcare worker population will follow.
So, Linda, within that context, do you have a concern? Because a lot of these workers who are delivering the food and doing the laundry and cleaning the building, they're lower paid. They tend to be people of color. Do you have a concern that there's going to be a racial inequity in the distribution of this vaccine early on as a result of this?
Well, you know, there are lots of things that will lead to probably a racial inequity in the distribution of the vaccine in the first place. And we go back to, you know, some vaccine hesitancy issues that are based in, you know, long history with people of color in the first place. So what I will say is what we know about COVID now is that, you know, it's that direct contact, that prolonged 15 minutes or longer contact with an individual, respiratory droplets, less about surfaces. So if people are doing the proper things in a hospital environment, then they should be relatively safe. And what we have seen so far has proven that. So what we're seeing really for the most part in the hospital and in the healthcare environment is that our employees are not getting sick from the workplace. They're getting sick from also going to small little social gatherings and things like that. And before you know it, they're sick as well. So before healthcare workers started to drop their guard a little bit as well, which, everybody did a little bit, I think, and then it's come back, I didn't wash my hands immediately when I came in the door for a little while there, but I did right at the beginning, So I think we all, dropped our guard a little bit. And that happened within the healthcare environment too. And they began to, have small gatherings, get together with friends and things like that. And that's where we're seeing healthcare workers get sick, as well as need to be quarantined because their household members have become sick in that way. I don't think that we're really seeing a significant number of infections that are coming from the workplace in the hospital in any of those groups, including the ones that you've mentioned.
Okay. So I want to transition a little bit to long-term care facilities. We know that we've had fairly significant outbreaks in our local long-term care facilities, which is sort of to be expected, right? Because we have people from the workers from the community going in to work, and that's going to bring the virus in. How prepared are we as a county to get the vaccines distributed and get people vaccinated in those long-term care facilities in Ingham County?
Well, that actually is happening in a very strategic way to begin with, so that as a county, we're not having to figure that out. The vaccine is actually being distributed directly to long-term care facilities via pharmacy partners. So they were able to sign up early on and make sure that they had that vaccine coming to them, and they had that partnership so that they have an ability to administer the vaccine within their setting. And so that really is all part of the deployment process, is to get the vaccine. The vaccine's not all coming, like H1N1, the vaccine all came to us. And then we had to get it pushed out, and we had to figure out, okay, healthcare, here are yours, or it may be that the healthcare system's got their own. It's been a few years, so I might not remember everything perfectly. But, we did have to work with making sure that many of the other things like long-term care facilities and things like that got their dosages of vaccine and had staff to be able to give them that vaccine. We didn't vaccinate everyone in that way. And so this is being deployed very differently. Instead of the health department being a central locus where all the vaccine is coming to, it's going directly to the healthcare systems. It's going sort of directly, but kind of in partnership to the long-term care facilities, so that all of that can happen fairly rapidly.
Okay, and within that context, then, what is the tracking and the documentation as it relates to making sure that the long-term care health workers have been vaccinated, that the long-term care residents have been vaccinated? What is there? I mean, if we've got private businesses involved, how are they tracking that information? And is that information that you as health officer are going to have access to?
Well, Dr. Shoyinka has worked with the long-term care facilities a whole lot more than I have. What I do know about vaccines in general, and then I'll let her fill in with, with her work with the long-term care facilities and how, she's stayed informed and abreast of a great many things. So she's got weekly meetings and relationships with them. But the other part of it is that every vaccination that is administered to anyone is entered into the state's care improvement registry, what used to be called the Childhood Immunization Registry, or MICR. So, it gets put into MICR. We have access to MICR, and that is one of the ways that we can always be tracking what's going on with vaccine, and that it is being, dosed and given in the appropriate places.
A quick follow-up before we move on too far past it. I'm curious why it's less centralized this time around through the health department. I mean, you mentioned that it's different this time. Why? I don't get it.
I don't know. Somebody at the federal level decided that, and what I'm seeing play out compared to what I saw for H1N1 is really a vastly different strategy in vaccine deployment and vaccination. maybe part of it was, health departments, and we do need to get back to Nike and long-term care facilities. But maybe part of it was, when H1N1 came through, we did these mass vaccination clinics. It's like people just come on in, get in line, get in big lines, get in another big line, and that's how we managed to vaccinate people very rapidly, right? We still need to vaccinate people rapidly, but we can't bring people into rooms in large groups and cram them together in lines in order for us as a system to vaccinate them rapidly. So in a sense, you do have to make sure that it gets out to a number of different places. Otherwise, it's not going to happen fast enough, because we cannot create these situations where we have, mass numbers of people coming in to get vaccinated, which is what we did with H1N1.
Dr. Shoyinka, did you want to weigh in on working with the long-term care facilities and vaccination there?
Right. So just like Linda said, NICR is the major way in which vaccinations are reported. Everything is reported in there. It is called the Children's Immunization Registry, but adults vaccinations are also reported in there. And over the last few years, I want to say that adults vaccinations, immunizations have been recorded even better than they were, initially when the registry was first created, or at least when the name changed. So that would be one major way where it can always be looked up to make sure that people are vaccinated. That's one way. The other important thing, though, is that in these long-term care facilities, like you rightly mentioned, a lot of staff are the ones who are really more of the people who move in and out of the community. And so it's imperative that they're vaccinated, and making sure that that happens is important. A lot of them also work in different facilities. Some of them work in like our major health system as our major health systems, and then also work in long-term care facilities. So there might be some double opportunities for some of them to get vaccinated. And, partnership here is really, really important in terms of sharing information. So there are plans underway to share that kind of information to make sure that we know that everyone who needs to get vaccinated is. And then of course, for the residents, that's a little simpler, right? As long as it's, within the facility, it's documented, consent is obtained from those residents, and then we just keep that information. But yeah, we've had to work a lot with the long-term care facilities, and we've developed some good partnerships. So I think we'll be able to support them.
So Linda, now since we brought it up, we're going to go there. There's a lot of vaccine hesitancy. In fact, about 50% of Americans are saying they're not sure they'll take this vaccine. We know that we need to have a 70 to 80% vaccination rate for immunity to have sort of that herd effect that we hear so much about. How are we going to overcome that vaccine hesitancy in this state and in this county?
We're going to have to create a lot of messaging targeted to specific populations of specific people related to the specific issues that they have that are causing that hesitancy. And we're going to have to really be boots on the ground doing outreach, really just doing outreach in the community, connecting with people in the places where they, worship, play, whatever, where the trusted place, they're trusted sources. The faith-based community is a trusted source for a lot of people, and working with the faith-based community to help get messaging out that often is effective in gaining people's trust. So one of the things that you have to do really is to work with those, for lack of a better word, trust brokers within those different populations and different groups, and use that as a method of gaining trust. Clearly, we've got to gain the trust of those other trust brokers first. I mean, my trust broker was Dr. Fauci and Dr. Murthy and Dr. Adams, who's the current Surgeon General. I had my, Nike and I talked about it early on. It's like, are we going to be first in line? I'm not sure. But, honestly, as soon as they came out strongly in support and strongly supporting the efficacy, the safety, the process that this vaccine has gone through, I don't have any concerns anymore. And so we have to figure out, those are the people I trusted, so that now I can, take that message on. Now I have to figure out who are the people that will trust me enough to carry that message on for me, for us. So it's going to be that kind of process, really.
So three of our former presidents, Bush, Bush, Clinton, and Obama have all said that they're prepared to take the vaccine on television. Will that help?
You know, I think that's going to help for the people who, again, trust them, right? It's all a matter of who do you respect and trust. And so, you know, we keep looking for, you know, and, you know, I'm one, I would do that. You know, I would go ahead and get a vaccine to show people that I don't have any concerns over it. But I also don't want to be pointed at and said, wait a minute, you're supposed to be tier 3 or tier 2. Why are you getting a vaccine now? So we have to be careful with, you know, the optics on that as well. But yes, I do think some of that vaccinating of people who have been leaders and who people trust and follow can be an important step in that, you know, building of trust across the population.
Quick follow-up on that, if I can.
Go ahead.
How much of this is a different animal, I guess, so to speak, to the vaccine hesitancy that we've seen out there? Because I mean, it's certainly not new that there's anti-vaxxers, but I guess, are we looking at, I mean, is this an insurmountable amount of hesitation compared to what we've seen on other vaccines? You spoke to it a little bit earlier on how, I guess, there's just a lot of misinformation with this virus in general in particular, but I guess to push you further, we've seen messaging on any other number of vaccines. What's different this time around? Because it's certainly a different virus too. Any thoughts on how to send that message home in ways that it hasn't been sent home before, I guess?
No, I don't know about, I think to answer your question, I think that it's a different animal from all the other, you know, anti-vax messages that we've heard in the context of this is all really new with very little data, no time to test any of it yet. And so even people who, just like Linda said, we've had that conversation, you know, early on, like we need more information to know about this, even despite who we are. Like, so that is why there's probably a lot more hesitancy, because there have been so many mixed messages and because it's so new. So even people who otherwise would be okay with it are hesitant and are going to take a minute to see. So we need to be clear on the safety, on the efficacy, and we need to be transparent about what side effects to expect, at least what we know, right? We know that it's a little more, the side effects may be a little more severe or tougher than a flu vaccine, a little more. Not anything that's going to knock you out for weeks or days, but, you know, flu-like symptoms, headaches, that kind of thing. And that also really depends on individuals too. So those kind of conversations as part of our messaging will be important to make sure that people know what to expect, and that kind of helps with the trust too, I think.
I think it's interesting. I mean, the virus itself has been politicized, whether you like it or not. So as a result, the vaccine is going to be politicized as well. So that's a kind of another element going on in the background of this whole thing. So it's not a question. I just don't envy your position.
Yeah, I mean, you know, that's probably the biggest barrier we have. I mean, you've got the small percentage, really, they're a small minority of anti-vaxxers. And then you have, you know, flu vaccine notoriously is not high uptake. A lot of people don't get flu vaccine because, you know, people don't think the flu is going to, you know, affect them that badly. And many other things. I'm young and I'm healthy. I don't need a flu vaccine, you know, all of those sorts of things. So we've got some of those issues to deal with too, you know, that are going to come along with this, because we do have, you know, a group of younger people who do tend to be asymptomatic or mildly ill, who may feel the very same way about this as they do with the flu vaccine. So we've got to get that angle in. But honestly, the hardest one is going to be that oh, this is, this is a conspiracy, and, it's, you're collecting my DNA, or you're injecting something in me to track me, or, that all of that stuff that's been out there is certainly the far, spectrum of the anti, or COVID hoax kind of thing. And then there are the people just think that, while it exists, it's not as bad as we've made it out to be. This is what people think, and that we're overreacting and those sorts of things. So they're the ones that, don't necessarily just think it's all a conspiracy and that we're doing something completely different, but still think that we've, really overreached, we've closed down, we've hurt our economy, all of those things. And so they're angry, and one of the things the last things they want to do right now is cooperate, with something like this. So that is going to be a very difficult barrier to get over. And whether messaging around, this is the way we're going to be able to keep things open for all of you who have been, yelling at us about the fact that things have not been open. We need you to get on board and help us. I really don't, we're going to have to work hard on some messaging around the various barriers and the various population groups that are going to have this hesitancy.
Do you think you're at an inherent disadvantage because that messaging is coming from Big Brother? I mean, you're a big brother in this situation.
We are at somewhat of a disadvantage, I think. I was actually talking to Todd yesterday about mandating vaccine, the healthcare systems and mandating vaccine. And the American Medical Association put out a really good article about, mandates and the fact that, that might cause more resistance, right? So it's government coming in and telling you what to do, and it's going to have the counter effect to what you expect it to have. And then public health, though government, is also a group of people that tend to work with the most vulnerable, the most disenfranchised people in our community. And so we have that, population of people that don't see us as the same kind of big government as some other government. And so one of the reasons that the AMA, made mention of that is if health departments come out and do this, mandate vaccine kind of thing, we also are risking further losing trust as a public health entity and getting grouped into that. You're just big government telling us what to do. Public health has got to maintain its trust with the community. We are government, but we are, oftentimes viewed through a little bit of a different lens than a lot of different government systems. And we've got to be able to continue to build on that in order to have that, that social capital to work with people in our community.
Within that trust question, I think it's important to ask this. You had to issue quarantine orders for multiple multi-person housing units in East Lansing as part of that student-related surge that happened. Are you fearful or concerned that that may have an impact, that negative impact of, oh, you're big brother, you're going to make us take this, they're not going to listen to your messaging? I mean, you had a lot of struggles with those students that were impacted in their families. Are we going to see the same thing, same pushback?
That was fairly intermittent, kind of a little blip on, it's not the generalized theme. I wouldn't say that that's the generalized theme in this community. Yeah, do you upset a few people with an order or something like that? Yes, we do, as did the state. Is it going to keep me from doing the right thing? No, it's not. Will it really be something that lingers with people? I'm not sure that is going to happen either. And again, that really, that's sort of like the anti-vax thing. It's more of a vocal minority than anything else.
So I want to be really clear. You at this time have no plans to issue a direct public health order requiring vaccination?
No, I do not.
Okay. Do you foresee any trigger point that would cause you to change that perspective?
I don't right now, no.
Okay. And then I think this is, Dr. Shoyinka, I am going to ask you a quick question going back to the vaccine. one of the myths that we continue to hear, and actually I had somebody ask on my Facebook page, is does this mRNA vaccine delivery, because this is the first time that we've had an effective vaccine through this delivery process, will that actually change somebody's DNA? That's the belief that I'm hearing.
No, this is the mRNA vaccine works in a specific way. It does have a genetic code that kind of directs production of a portion of the COVID virus, right? They call it like a spike protein. And it's not the virus itself. It's not going to induce, cause infection. If you look at the CDC website, they'll say it's a harmless piece of the COVID virus. And so that's what goes into the cell and directs, production of that spike protein that needs to show up on the body cell that the body now, the immune system recognizes as part of the COVID, SARS-CoV virus, right? And so subsequently, the body now reacts to that spike protein, and then you develop the immunity. So that's really what it does. It doesn't it doesn't change anything. It directs production of a specific material.
Let's keep in mind that that's how viruses work, right?
Yeah.
A virus does not exist without basically hijacking the cells of your body to use the machinery that reproduce DNA or RNA in this case through these cells in your body and all of the ribosomes and all of the enzymes and all of the everything, because it doesn't have any of that. It uses all of that in your cells in order to create more of itself, which makes it sick, you sick, and which allows you to spew it out and make others sick, right? That's what viruses do. So if a virus is coming into our body and injecting its RNA into our cells, which is exactly what it's doing, and that's not changing our genetic code, then why would a portion of said virus that happens to go into you via a shot in the arm rather than inhaled through your nostrils do anything different?
And then I think this is sort of the last question that I have, and then Kyle, if you have anything else, please jump in. But we are seeing a massive surge nationally. And we're starting to see that leveling off a little bit, I think, from the numbers that you showed us earlier this week. But we anticipate that Thanksgiving holiday is going to cause a spike. We're not having this vaccine available in very limited amounts does not mean that this crisis is over, correct? We're looking at probably a year before we're back to quote unquote normal. Is that an accurate assessment?
I keep hoping for less than a year, and then Nike always bursts my bubble.
Let's just say I'm trying to be realistic and optimistic at the same time. But yeah, again, like we said, we don't know how well or how long the vaccine will induce immunity. So that's a critical piece. Most vaccines, that immunity will begin to build within, the first couple of weeks or so after it's been obtained. I'm not clear about what exactly that looks like. Also note that this vaccine requires 2 doses, right? So that full immunity is not going to kick in until at least a month when you get the second one. So each person that takes it, we still have at least a month and 2 before everyone displays some level of immunity, and then we don't know how long that's going to last. So again, back to your earlier question, is this something that we're going to have to take annually or biannually? We still don't know. So yes, we still have a long ways to go. I would say a minimum is a year. It might be more. Sorry, Linda.
Bursting my bubble all the time.
Truth does that sometimes.
Remember, we're also tiering the vaccine, right? It's not like everybody's getting it on the same day. I mean, by the time we get to phase 2, we're talking about March or something before people start getting it. So that pushes things way into, the spring, summer, and then we have time to wait to see what that looks like.
So that March is when the general public is
About
going to
that,
expect it to be that. Yeah. Okay. I just wanted to clarify because we're hitting our target audiences first, our targets first, and then expand from there. All right. Is there anything that we didn't ask you that you think is important for our readers to know about the vaccine and the ongoing coronavirus crisis and within the context of public health?
No, I think we covered a lot.
Yes, we did. Kyle, did you have any follow-ups?
No, I'm a little disappointed to hear that we're not having some DNA bending Spider-Man vaccines out here, though.
sorry.
Sorry.
Actually,
Sciencey on you and tell you that's the way every single virus works. It injects its DNA or it's an RNA into your cells. It hijacks it. It uses all your machinery to create more of it.
You should listen to
That's
her.
how they work.
Microbiologist.
I think we covered everything that was on my list. The only thing I wanted to be sure about, I know you were not going to hear a mandate, at least from the Ingham County Health Department, for a vaccine, but employers, are they free to mandate vaccines if and when they become readily available?
They are. You do see healthcare systems that like mandate flu vaccine, and it is entirely possible that you will see some healthcare systems that will, by policy, require vaccination. I don't know. They're gonna deal with some of the very same issues that you're talking about, challenges with us in mandating that by policy. So that could very well be a challenge for them, but they do have the ability to do that, and some do for flu vaccine for sure. So hepatitis A required for healthcare workers. There are a number of vaccinations that just flat out required for healthcare workers, and whether we go to a point where this one is one of them. That will depend on the healthcare systems and how they decide to move forward with that.
So following that up a little bit, so healthcare systems, yes. What about GM? Can GM legally require everybody to get this vaccine, or are there going to be some legal issues related to that, or is this one of those things where we're sort of feeling our way through the dark on this?
I am not sure, but I think that every employer can, pretty much indicate what they would require depending on, as long as they can express what the risk is and of course have a legal backing for it. It'll be interesting to see what support that those kind of organizations would get from like OSHA and things like that with regards to that. So I don't think that's clear.
I think in general, an employer does have the ability to do that by policy. How well it stands up if it's pushed back against is a question. You see, just to go completely off topic, but when I was in Kalamazoo Valley Community College, if you were a smoker, you couldn't work there. That was their.
It'll be interesting to see if it develops.
Their healthcare costs considerably. So that's a policy. They can do that. So employers can create policies around health-related things like smoking and not smoking and needing vaccinations and things like that. So it's not always easy, but they can do it.
Another place, just thinking about what Linda said, is another, entity that might be able to support some of this might be insurance companies. You just like similar to smoking, you get some kind of incentive for, not smoking and for keeping your weight down. So maybe this might be one of them. That might be another strategy.
Yeah.
It'd be interesting to see if this develops into like a recommended best practice thing for businesses. And before the mandates for different COVID precautions were around, I know there were some businesses that went above and beyond to make sure they were doing something. So, hey, we're not letting you work here unless you get a COVID vaccine might be the next top trend. We'll see.
You do already have,
because, look at the way it's closing down their businesses. They're going to want to do things that are going to, avoid closing down their businesses. So.
And similar to that, a lot of employers, would ask for like a negative COVID test before people come back to work and things like that, even though there are no like major rules to support that, but that's something that they would decide to do internally, though we don't always recommend that. But
Sure.
When you talked about the insurance companies, you did raise another question for me, so I'm going to have to throw this out there, and that is, will this vaccine be free? I mean, the government did pay for it,
To
so
my knowledge, the vaccine will be free. Now, I was reading the Illinois Department of Health, everybody's got these draft, plans.
right.
And they really look all the same. I wandered around from state to state and everybody's got the same template. The one that you sent yesterday looks just like the one I saw from Louisiana, looks just like the one I saw from Idaho. So I was looking at Illinois, and Illinois did talk about the vaccine distribution through the existing Vaccines for Children provider network system. Now, once the vaccine gets into that system, and Vaccine for Children is free, so this is why I want to put a caveat on it. The vaccine itself might be free. There may be an administration fee. So, because it takes personnel time and that sort of thing. So sometimes you see an administration fee with a vaccine that essentially is a free vaccine. So, people are like, oh, you said it was going to be free and you charged me $10. It's like, well, that's an administration fee. The vaccine itself was free. So I'm fairly certain that we won't be doing that because it is our mission and our role to get out there and make sure that this vaccination happens in the public. And that's what our staff are here for anyway. So that's what my staff time is intended to do. But in a provider office, you may encounter something like an administration fee.
Okay, all right. Kyle, anything else?
I'm set. Thank you, guys. I really appreciate you taking the time.
Yeah, we
Okay.
really appreciate you guys. Thank you so much.
Thanks.